OsteoSignal Episode 5. This is OsteoSignal with Neal O'Neal, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Hello, I'm Neal O'Neal, an osteopathically trained manual physical therapist, and I've been working with patients, hundreds of thousands of patient hours of treatment, and studying on how to help patients better. A lot of in-depth analysis of anatomy, physiology, embryology, and pathology, and how things break down. So, trying to understand the human body from all those aspects.
I'm Autumn Mayberry. I'm an osteopathic manual practitioner that I've studied under Neal for quite a while and some of our other mentors. And we are just talking about ways that our patients and then just general public can be smarter about how they, understand their bodies and the things that they are given opportunities to do or not do with them, medically speaking or otherwise.
Awesome. My name is Brent Mayberry. I'm Autumn's husband, and I'm just here to kind of be a fly on the wall and just jump in with any questions that, a listener might have about this awesome stuff. So,
Well, thanks
all
for
right.
being here.
Yeah, thanks, Neal. Let's start in. What would you like to talk about this afternoon?
Well, Autumn, you had kind of talked about, you had sent me a text about either the two neuron, three neuron problem. Why don't you kind of help formulate, like, what do you mean by that? What do you mean by two neurons and three neurons?
Well, in a practical, layperson, how it kind of manifests, that's what we get from our patients, right? The report that, hey, this is just unbearable pain, or like, well, let's back up a little bit. I guess when I treat people, they have, backaches or they have knee pain or they have a headache or a tight neck or things like that, normal musculoskeletal um, pain or their body just isn't behaving the way it should, right? There's discomfort with it. Then I have patients sometimes that come and say, I'm just ready to scream my head off or put my fingers through my skull with, gripping my head because the pain is so bad and nothing touches it. That kind of pain, right? And both of those patients come to us and we do really well with the latter, or the primary one, but the latter one seems to take medications or other things that are much more, elevated approach to be able to get rid of them because our normal techniques of the restoring function, right, doesn't seem to cut it with those individuals.
Right. And I think that's a real difficult thing for most people to understand, because the patient comes in and says, look, doc, here's where it hurts. I can tell you everything you need to know. It's right here. It's this thing. And that is like you were saying, like a two neuron problem. Like, people have this idea, and the two neuron problem is somewhat based upon like a knee jerk reflex, right? If we take a reflex hammer and we tap the patellar tendon, and the patient can see that you've tapped the patellar tendon, that nerve took information back to the spinal cord. Uh, Now it's actually, there's an interneuron that transfers the information to a motor neuron that says, hey, make the quadriceps fire. And so the person's knee will jerk. And so patients tend to think in that two neuron problem sort of mentality, going, hey, this is real direct. There's a pain here, and my sensory neuron can sense that pain, and it's coming in, and then yes, my muscles are guarding, but it's because it's this local problem, it's a very direct problem.
Hmm.
And as you said, like, when in events of, like, say, uh, direct trauma or things like that, or where there's edema or swelling for whatever reason, like somebody cut themselves or they fell and bruised themselves or whatever, then that approach can actually be very useful. Or even if they've exercised and they've really overused that muscle and that muscle's hurting, and they're like, oh yeah, this is terrible. And then of course you work out their quad or something, and they go, oh man, I feel way better. And so that's a kind of what we call the two neuron problem. Like, okay, that's straightforward every day. The problem is that that's not anything that's been there any length of time. That's not how it really functions, right? So what you're kind of talking about is there's actually a third neuron. So there are three neurons for sensory pain, or for sensory, not pain, um, for sensory, for sensation into your brain, right? So there's the neuron from, say, let's say you hit your thumb with a hammer. You're hammering something and you miss and you hit your thumb, and the pain shoots up your arm, and it goes into your spinal cord. And then spinal cord, that sensory neuron then feeds the information to a secondary uh, sensory neuron. That's called usually in the spinothalamic tract. Let's say that again. The spinothalamic tract will take that information from the spinal cord up to, in this case, obviously the thalamus. There are other places that information can go. It can also go to the cerebral cortex. But the thalamus, hypothalamus, limbic system will take that information in. And then there's a third neuron in the brain saying, hey, there are other parts of the brain that need to see this information. Okay. So there are other places where that neuron, so that you get your first neuron that takes it in from the thumb to the spinal cord. Your second neuron takes the information from the spinal cord up to the brain somewhere, right? Then the third neuron is, now which neuron is that? Is that a thalamus that says, hey, this is a flight or fight situation. We need to pull back our thumb. And obviously the local reflex to the spinal cord already calls you to pull back your thumb. That's a 2-neuron problem. But not only do I need to pull back my thumb, I need to shake it and throw the hammer and kick it and get mad and fight the hammer. Right? It's all the hammer's fault. Okay, but that third neuron, so then that's where emotion gets attached to it. That's where other processes like, oh, well, how will this never happen again? You know what? I'm going to get rid of all the hammers in the house and I'm only going to use a nail gun. That'll never happen again. Whereas I'll only ever use screws from now on, no more nails. So, and then there's other motor responses. So part of it might be that you also develop stiffness in your shoulder and neck because of this irritation of the brain from the pain, or what is deemed as pain in your brain. And so then that third neuron causes a lot of other problems, partially because it's also that third neuron might be cause a sympathetic reflex or an autonomic reflex. And so there's illness behavior. The illness behavior is the classic example of this. There's something going on in your body, your vagus nerve or your sympathetic nerves pick that information up, take it back to the spinal cord. Now, in this case, that'll be the brainstem, right? Because the second neuron, the second order neuron in an autonomic setting is in the brainstem. So that the sympathetics will take that back in, but they too go up to the brainstem and say, hey, hypothalamus, here's the information from the sympathetics, and the vagus or the other parasympathetic nerves will bring that in. Trigeminal nerve brings information in, and then that information is given over to the hypothalamus. And so then that's the second order neuron. And then the hypothalamus itself says, well, where should I send this problem? Should I send this problem to higher centers to be thought about? Or is this something that I should ignore? Or, and often what we see, especially in autonomic, is the higher centers say, yeah, that's great, but we don't care. Yeah, the boss is a jerk. Yes, we have a deadline. We don't care. Keep working. Forget the fight or flight situation. We're going to sit here and do our job. So that's that third neuron. Now, the problem with that is that at every one of those levels, there is some motor response that comes out. So the first order neuron goes directly to the spinal cord. And like we talked about, like with the knee jerk the knee jerk reflex, that you're going to get a response, just an immediate one of okay, so I pulled back my thumb immediately.
Mm-hmm.
Then
Sure.
as that spinothalamic tract information goes up, then it's, the hypothalamus sends an information back down and says, hey, shake your thumb. That'll help. Then that third order neuron gets up to the brain, and the brain makes some decisions about, I hate hammers. I've always hated hammers. I hate this hammer. So that's where you see this third order neuron, and then its motor response is, okay, now I want you to throw the hammer. Now I want you to kick the hammer, something like that. Okay. Yeah. So you can see those three orders. The problem is that third order neuron, it doesn't just necessarily go away, because then after that, you harbor a grudge against hammers. Or maybe this hammer has a black handle, and from then on out, you won't use, hammers with a black handle from Ace Hardware, right? Because it had Ace Hardware written on the hammer. And so that's the part that when a patient comes in and they're saying, I'm having this problem, and our job is to say, okay, is this that simple reflex? Was this a recent trauma? Is this something that we can see as the first neuron? Is it gone up higher up into the brain stem and they're getting a response? And so it's a second order neuron. Or has this gone all the way to the third, that it's changed how they're doing things, that it's actually affected multiple neurons in the brain, and that they're getting a tertiary, a third order response that goes on in time. And so they come in and tell you that, oh, yeah, my neck and shoulder just won't relax, just won't let go. But that irritation is coming because when they smack their thumb with the hammer, they actually cause some problems that have not gone away. And so there's minor feedback through the thumb back up those three neurons, and so the circuit is still uh, setting off, if you will. And so you continue to get three levels of motor response. And so
Right.
you and I, as advanced therapists, have to look at all three of those levels and go, well, this isn't direct trauma. They didn't just hit their thumb. And there's nothing I can do about the immediate trauma. Like, well, use ice. The second order neuron, maybe the movement pattern is off because the joint, when they tried to pull the thumb back, when they hit it with a hammer, they jammed the joint, or the
Hmm.
inflammation jammed the joint. So then you and I will work on the thumb and say, okay, I can make the thumb joint work better, maybe stretch those muscles and stuff. And so as we go up those orders of neurons, then we say, okay, now third order neuron, what am I going to do about this? Like, do I have to do biofeedback to get them to stop heating black handled hammers that say Ace Hardware on the side? Or is it that I have to do some higher order neuron treatment? Do I have to do a cranial treatment? Do I have to treat their sympathetic nervous system as it comes into the spine? Do I have to um, affect a ganglia, like a sympathetic or a parasympathetic ganglia somewhere that is being ramped up by this? And then that way I can get the neck and shoulder. Now I can go and treat my patient's neck and shoulder. And because they don't have information from any of those three neurons of the first order, second order, third order to come in there, now that fight or flight mechanism and that continued dysfunction in the area can turn off.
Right. Right. And in situations where we have like a tumor, for example, right? Because at some point they start to cause pain. And so when we go and say, oh, well, their back is stiff here, and we do our regular treatment for mobilizing, vertebrae or taking tension off the diaphragm or whatever the case might be, and that doesn't relieve it, then that's where we're engaging that third response.
Correct. Yeah, right. Because then you've looked at your first order, you've looked at your second order, um, and then finally you're doing a third order saying, and then obviously, like I said, like you want to go back and look at those ganglia. For example, parasympathetic ganglia are in the wall of the organ, and that's a very important thing to know because if you go and press in an area and you can elicit pain and say, "Oh yeah, you press on that thing, and that caused
Hmm.
that pain in my back." In between my shoulder blades. And you go, oh, that's unfortunate because that's a lump feeling thing in your small intestine. And that tells us that maybe there's something going on there that's a bigger problem. Um, and then exactly now, maybe you can't fix that, but it certainly gives you the idea of, oh, geez, I just pressed on this thing that's somewhere, either gallbladder, small intestine, uh, uh, some structure like that, that you go, okay, well, that will shoot in between your shoulder blades. And gee, gallbladder is 6, 7 on the right. Pancreas is 6, 7, 8 on the right. Maybe it's one of those structures. And then that's when like, okay, maybe it's time to refer somebody out, or maybe this
Exactly.
is just gallstones and let's help it move better.
Hmm.
Yeah, right.
But you
If we
wouldn't,
can't, let's see if
as
we
a
can get.
manual therapist, be like, well, this is going to be a bread and butter patient. They're going to come every week for, you know, you kind of go, okay, I'm going to give a valiant effort on this, and then if it doesn't get very better, we need to have a doctor look at this.
Entirely, because
Yep.
not everybody has a tumor, right? And if you kind of go, well, this
Sure.
is low grade, so this is somebody that I'm going to have to treat because I have to get that GI tract to function together more properly, right? You have to do Bennett's
Hmm.
technique of getting the lower structures to tell the higher structures when to do their job appropriately, and
Yep.
which does kind of go back to that third neuron. Like, okay, the third neuron doesn't always have to be in the brain. Sometimes it's in the enteric nervous system,
Yeah. Yeah.
right? So
That's true.
tracking it down can be very difficult.
Could I just jump in and ask, what's the enteric nervous system?
So the enteric nervous system is the inherent nervous system that runs the intestinal tract. So there are nerves that line your gastrointestinal tract and innervate like the walls of your organs. That when they're stretched, it gives them feedback, and they say, "Oh, there's something coming through here, probably food. We should do something about that." And for example, when you're tongue, when you put food in your mouth, your tongue registers what's in the food, and it tells your digestive tract, hey, we have 40% fat, 40% protein, 20% carbohydrates coming your way, so get ready to break that down. So this enteric nervous system is the nervous system that runs the entire gut on its own.
Amazing. Okay,
Yep.
thank you.
And then I guess that's where the third order neuron comes in, is that the sympathetics and the parasympathetics oversee that enteric nervous system. They say, you do a good job, but you're kind of slow, and you're slow and steady, only work at one pace. It's important for us to have, sometimes we need things to work faster, and sometimes we need things to work slower. Like, hey, we're busy running from a tiger. Can you stop using all the blood to digest lunch? Otherwise, we're going to
Yes.
be lunch.
Yes.
I was going to ask
Right.
also, so is the enteric nervous system simply sensory, or does it get instructions from the parasympathetic and sympathetic systems to actually do something to the gut?
Well, it's sensory and
Like
motor, right?
contract and send the food along to the next
Right, like the
section.
peristalsis. Yeah. So
Yeah.
that's that kind of back to our original discussion. That's like a first order neuron thing. You have a sensory neuron take information in, and then it causes a local reflex muscular action. Right. And then, but you might have a second order neuron that says, hey, I'm this stomach and I'm getting stretched here. And so now that the muscular component that I want to cause is the stomach to start to churn and mix up what's in the stomach. However, I'm going to send information to the local ganglia that's going to take that information and then tell the pancreas, hey, get ready. Here comes this food. And I'm going to start doing it in 15 minutes. You're going to have to start really pouring stuff onto this. Right. So that's our second order neuron. And then there might be something like, oh gosh, I've eaten this food, I'm digesting it, and I'm actually really worried about I have a job interview coming up, and so now I'm very worried about that. And so that third order neuron will come down, and the parasympathetics in this case will say, you know what? You don't need to do such a great job digesting that. How about you just rush that along? And by the way, we need to go to the bathroom. Let's go
Yes.
get rid of that. Right? Like
Yep.
a nurse foul. So that fits perfectly in it, because the enteric nervous system is another one of those things, like your knee, that has its function, but that function is overseen by this first order, second order, third order neuron idea.
Yep. That's really
Yeah,
cool.
yeah, and it's very important for
Amazing.
patients to understand this, right? So that they can kind of go, oh, that's why. Like when I come and see Autumn doesn't just go and treat the thing that hurts.
Yes, we're famous for that. Like, I know you're gonna wiggle my big toe because I said my head
Right.
hurts. You're like, yeah, maybe.
And that's where but practitioners who do immediately go and draw a 6-inch box around whatever the problem is and say, well, the fix must be here. They're not exhibiting enough nuance and finesse in their treatment and enough knowledge. So it would be good for everyone and patients to be able to demand that, hey, I want you to look at more than just, and of course everyone's saying, hey, we're getting down to root causes. Everybody thinks the root cause is still in the 6-inch box. A root cause is like we said, if it's not direct trauma, it's not in the 6-inch box. The root
Right.
cause is outside of that.
Yep. So what would you say, like, because sometimes I struggle to explain that to patients, like, how would you tell them, hey, this is something that you need to come see me about? And then, this is it's in the middle of the night, you need to go to the ER kind of thing. What would you say that to explain that to a layperson? Like, how would they choose most wisely?
Something that,
And
yeah, I
granted, there's
think,
always going to be exceptions, but
right. One of the things I tell patients all the time is like, look, if you have a pain that gets worse with rest, and not one of those ones like we all have pain at rest where you're like, oh, it's uncomfortable, and people will say I can't get to sleep, but then they slept 6 hours instead of 8 or 9. Not that
Mhm.
pain, but that pain that you have to get up and move around. That's probably
Yeah,
pain to go and see the
I
doctor.
can't lay down. I can't sit up. I'd have to sit up sleeping or that kind of stuff. That's the scary stuff. The third order thing.
Yeah, it's like,
Yeah.
oh, go to the doctor.
Yep. Yeah, especially if we're like, "I've treated you and we're done." So, yeah. All right.
Yes.
Well, that's really helpful. So, thank you so
Okay.
much, Neal.
Awesome. All right.
Thanks, Neal. We'll talk to you next week.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neal. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neal.